So tarsal tunnel. Today is tarsal tunnel syndrome. I like to categorize them as two. The front, which is anterior tarsal tunnel, which involves a nerve called the superficial peroneal nerve, which is a sensory nerve. There are three types of nerves: sensory, mixed, and motor. Motor is for function. Sensory is obviously sensation, and mixed is both. So this is a sensory nerve. It's called the superficial peroneal, most commonly due to tendonitis or engorged vein or mechanical changes, arthritic changes, systemic changes. In his situation, it was severe arthritis, buildup of bone spurs due to a foot type and congenital anomalies that we will see later on the x-rays. Recovery is phenomenal, very quick. You want him to mobilize and get into physical therapy immediately to resolve the paresthesias that was the paresthesias by definition is the tingling, numbness, burning, symptomatic pain, numbness. All that has to be resolved fairly quick by mobilizing and removing the scar tissue and having a functional foot. In this situation, he had this done by another provider. Apparently it was done on along this side. The newer ones, which are the darker ones, are the incisions that resolved all his arthritic phenomena, as we see right in the front and right on the side. The side resolved the tarsal metatarsals as well as the instep. From one incision, you can undermine and tunnel it and resolve and rasp them down manually, by the way. Nothing mechanical or pneumatic. It does create a vacuum. It will create problems that you do not want to address. So everything has to be done manually with osteotomes as well as rongeurs and hand instrumentation, which is like rasping, Joseph rasp, or multiple rasps, which are to sand it down, to smooth the bone down. The front as well, as you can clearly see. So this is anterior tarsal tunnel, which is the superficial peroneal nerve, and you are decompressing, releasing, or removing spurs to allow the nerve to function properly without irritations of the soft tissue that is imposing on the nerve, such as inflammation, tendonitis, due to the irritation from the spurs. So before we jump to the posterior tarsal tunnel, which is the tibial, which is a mixed nerve, I like the hockey stick incision, as you can clearly see, but we'll get to it in a minute. As we go to the x-rays, this is what he had before. So the spurs on the top, clearly fairly large along the instep as well as the back part of the hindfoot. As we can see, the skin is actually lifted up. And from a clinical standpoint, one would assume he had a big lump, firm lump on the top in front of the ankle. And all these are fragmenting because of motion. And as you can see, the inflammation of the soft tissue. He has obviously a plantar spur on the bottom with the thickening of the plantar fascia, which is the white band on the bottom. He did undergo a procedure on the bottom 7 years ago by a different provider. I do not like these incisions from the bottom. I don't see the need for them. The complications are tremendous, and the heel is that first hits the ground. As we can see, 7 years later, he still has indentations. And also, to address the spur is secondarily. You want to address the primary cause and the root of the problem, which is the thickening of the plantar fascia, which is the origin of the tightness and the thickening and the lack of pliability pulling onto the bone, and the bone then produces the spur. So the spur is not the cause of the pain, it's the thickening of the plantar fascia that needs to be addressed and released. But furthermore, along the bend, which is the muscle along that area of the foot, there's a muscle in the foot and there's an opening that needs to be addressed. It's called the hiatus, which is an opening where the nerve enters, as well as there is a myofascia, which is very tight along the intrinsic muscle, which is a muscle of the foot. Some people believe it's a continuation of the plantar fascia that goes upwards. So nonetheless, that I do release, and also I release all the structures along the incision. So incisions of the posterior tarsal tunnel in comparison to anterior tarsal tunnel, we understand there are two different types. So we will talk about the hockey stick incision versus transverse incision. But before we do that, I will show you the after, I apologize, of the resection of the spurs on the top of the foot. And now we can see it's very smooth. There is no more lumps and bumps. This was done first. Then a few weeks later, we addressed the posterior tarsal tunnel. So now I will put this on here for a second, while again, we saw this right there. And I will show you the after surgery of these spurs. So I will put this away for a sec. And I will look at the same image without names. As we can see, this is after, and we saw the spurs still there. I do not go after spurs. As we can see now, the structure is much padded above. There's no more spurs, and it's all cleaned up very, very well in comparison to before. So that is the same individual, as we can see from the heel, if comparison to the other study. So this is after surgery for the anterior tarsal tunnel, and his situation was removal of the spurs. So now we will talk about the posterior tarsal tunnel release. I like to address it with a hockey stick rather than a transverse. A transverse is from the bend of the ankle down to the superior aspect of the, which is the top part of the heel, and it goes along the tension lines, which is the skin relaxed tension lines. The philosophy is that you want to go with the grain rather than against the grain. So this goes against the grain, perpendicular, and the high up to 40% recurrence due to the incision and scarring, as well as the opening of the wound called the dehiscence. So the wound opens up. So that's why people avoid the hockey stick, or they make them smaller rather than longer. I do what needs to be done. So I do follow MRIs. I do follow nerve conduction velocities, EMG studies. I do follow clinical studies on him, such as nerve conduction testing, pressing on a nerve, Tinel, which is a sign called Tinel sign, which is radiation of the symptoms. There is Veloux sign. There is a modified phalanx, which was a adaptation from the hand. So by plantar flexing the foot and inverting the foot, that would create the symptoms that the patient would intensify by tensing the nerve, as well as the deeper tissue along the compartment. I usually address it with such. The only thing is you want to cut not over the nerve. So what I usually do is palpate and feel the pulse. If you can't palpate it, use a Doppler, and then I would go along a tendon. I follow a tendon. Same thing when I do broken bones. I follow along the long bone. Try to avoid complications, and you do the incision very tediously and carefully. In his situation, I do not put tourniquet. I like to address the problem right there and then. There are a lot of blood vessels that need to be addressed, and if you have done that without a tourniquet, there is no more draining hematoma or excessive inflammation that is called a seroma that would cause more complications of post-op that would lead to opening of the wound called dehiscence and ulcerations of the incision. So in his situation, what I did is release the flexor retinacula and also the deeper tissue. Please do be mind, do not use absorbable, dissolvable sutures deep. Obviously, after release, you do not want to repair that what you released, and you can use obviously superficially absorbable but minimized due to the inflammatory effect that you will get scarring. This is 4 weeks after, which is phenomenal. This appears to you guys as open, but it actually is not. It's very, very healthy. So what I do as well, address the plantar fascia from the bottom part of the incision, as well as the myofascia release. The abductor hiatus, which is the opening where the nerve enters, I also release, and the flexor retinacula. And also the visibility is phenomenal in comparison to the transverse. I address anything, be it varicosities or any space occupying lesion, that I want to make sure the nerve is moving freely. As you can see, this healed very well 4 weeks after. If you want to see the surgery itself, you can find it also on my YouTube channel, and that showed exactly how I was able to put my finger into the bottom of the heel and addressing the problem of the plantar fascia and the nerve structures in the area. This is in a nutshell a posterior tarsal tunnel release, anterior tarsal tunnel release, and also something that I do not like, which was done by a different provider is 7 years ago, is a supposedly to address the plantar spur and the plantar fascia, which clearly we see on the x-rays are still there. Otherwise, this is a tutorial. If you do undergo a tarsal tunnel, please look at those things in regards to, if it is localized in the ankle versus from higher up, be it the leg or in the lower back. So it needs to be addressed by that. And this situation was localized at the ankle level, and that could be addressed very nicely from our situation. So thank you again for watching this. This was a tarsal tunnel release from the front and a tarsal release from the bottom. And hopefully that was very helpful. Again, thank you. Bye-bye.